Acha. So when we discussed the optic nerve, the anatomy of the optic nerve, we discussed two diseases last time around. So one of the diseases was due to increased CSF pressure in this subarachnoid space, increased amount of CSF in the subarachnoid space, right? Because we know that the eye, it's an extension of the brain. Changes in brain pressure can manifest the changes in, can cause pressure change यहाँ भी होता है several times. So this is one of the diseases which is studied, increase in pressure of CSF, which was termed papilledema. The second was demyelinating disease, optic neuritis due to multiple sclerosis, in which the covering of this nerve sheath, it is being affected. Okay, the demyelination presented with painful eye movements, loss of contrast sensitivity, RAPV, all that stuff. So oligodendrocytes, because it's not a true nerve, it's part of the CNS. Oligodendrocytes, they form the myelin sheath of the optic nerve. तो हमने दो चीजें देख ली. Now, what will happen if something affects this artery over here, which is present in the center? ये जो जा रही है. If this is affected, let's say it's occluded, the disease entity which will happen will be called, what will be called? वही तो जवाब दे दे. It will be called which occlusion? कौन सी artery occlude हो रही है?
Central retinal.
Central retinal artery occlusion, right? It's very simple. Central retinal artery occlusion. Similarly, if this thing over here, if this is occluded, this is the central vein of the retina. This will manifest as a central retinal vein occlusion. अच्छा, ये तो हमने देख लिया. We've discussed these in retina, and we will discuss these in retina in our future sessions. Now, what will happen if these small vessels, so यहाँ है, these ones, right? These short posterior ciliary arteries between anatomy इनकी है. What will happen if these are, if there's something wrong with them? If these are blocked, they are occluded. फिर क्या होगा? क्या होगा? This is the topic of today's session. And इसके साथ-साथ we'll discuss a few other things as well. So let's start with our first case of the day immediately. Take a look at the history. So what's important in this history? Okay, let's go step by step. The first thing which is important is the age of the patient. What is the age of the patient? It is 53 years. Okay, first important thing. Second important thing, this patient has comorbids. What is the first comorbid? Diabetic retinopathy. Not retinopathy, he is diabetic. Okay. Correlating with the age, it's most likely type 2 diabetes mellitus. Okay, the first thing. Second is he is hypertensive as well. Okay. So a little bit about the comorbids. Presents to you with acute loss of vision in his right eye. So the chief presenting complaint is acute uniocular or unilateral loss of vision. What can be our differentials of acute loss of vision in this patient who is diabetic and who is hypertensive? क्या differentials हैं which should come into our mind based on just this initial sentence? What's the first diagnosis?
Central retinal artery occlusion.
Yes, the first differential is CRAO, central retinal artery occlusion. What is your second diagnosis? Differential diagnosis. रेटिना वाली आवाम
Diabetic
retinopathy. रेटिना वाली आवाम का दिमाग है
macular degeneration.
Macular degeneration. Which type? Type wet ARMT. Okay. Dry type takes usually it's insidious. Similarly, diabetic retinopathy is also insidious. It takes a long time. Yes, what one? It takes a long time. Hypertensive retinopathy takes a long time. Okay? They have gradual losses of vision. This patient has acute loss of vision. CRAO हो गया, wet ARMT हो गया, और क्या हो सकता है? You say diabetic retinopathy, think about the complications of diabetic retinopathy. Can the person be suffering from
Vitreous
complications?
hemorrhage.
Optic neuropathy.
Vitreous
Ischemic
hemorrhage.
optic neuropathy.
Vitreous hemorrhage, ठीक है.
Ischemic optic neuropathy.
Ischemic optic neuropathy, Aion. I'm abbreviating it as Aion. Another complication of diabetic retinopathy also occurs in other cases and presents with acute
Detachment.
loss of vision.
Retinal detachment.
RD, retinal detachment. Okay. So based on your previous knowledge and on the symptomatology and the comorbids, you can have a few differential diagnoses. So let us see which one of these are. आगे हम history पढ़ते हैं. Yesterday he woke up in the morning with decreased vision in his right eye. He reports no pain, denies floaters and diplopia. Floaters are usually present in retinal detachment. अगर इन डिफरेंसेस में से हम बात करें और विट्रस हेमरेज में भी होते हैं. He denies floaters. That he is denying something coming in front of his eye or his visual field and something which is floating when he looks at a blank area. Let's look at the sky when you look at the white wall. So थोड़ा सा unlikely हो रहा है vitreous hemorrhage in RT, but we cannot rule them out still. We need to do investigations. We need to examine the patient. So let's work up our patient profile. So first thing, when we perform थोड़ी सी ocular examinations देख लेते हैं. We know that we'll have to check his visual acuity, and his visual acuity is 20 करते हैं, चलो 20 का 6 meters or 20 feet. So it's 6 by 30 कर लेते हैं, चलो 6 by 30 in his right eye. He's a right eye, okay? And it's normal, or 6 by 6 in his right eye, left eye. Which other things which we want to perform? Acute loss of vision in his right eye. Okay, it's painless. So that is why इस patient में acute angle glaucoma भी हो सकता है. So we can also perform a tonometry or a gonioscopy as well. और आप क्या कर सकते हैं, क्या करना चाहेंगे?
Endoscopy.
Tonometry and gonio. IOP is normal. And the angle is open. So, third thing, अभी हम दो डिसीजेस पहले कवर कर चुके हैं. फंडोस्कोपी से पहले कोई और क्लिनिकल एग्जामिनेशन या उसके साथ कोई और आप करना पसंद करेंगे?
Slit lamp.
स्टेट लैम्प, ठीक है. तो स्टेट लैम्प पेरीमेट्री हम इन्वेस्टिगेशन में डाल देते हैं. कोई और क्लिनिकल एग्जामिनेशन?
B scan.
Clinical
Reflex.
exam.
Pupillary reflex.
Pupillary reflex, ठीक है. Pupillary reflex is an examination. B scan is an investigation. One more examination. एक और examination. Extra ocular movements, ठीक है. You should perform these. क्यों perform करेंगे हम? सबसे पहले मैंने ऐसे ज्यादा ही कह दिया. So the first thing is you want to perform a slit lamp examination. So interior compartments in the chambers are normal. कोई मसला नहीं आके. Perform an examination of the fundus or a funduscopy. The rest of the retina is somewhat normal. This is what you see when you examine the optic disc. एक तो बड़ा सारा arrow इस तस्वीर के अंदर लगा हुआ है. You should know what that is. But what can you tell me about the optic disc?
Blurred margins and hemorrhage.
Blurred margins. So there are blurred margins. There's a hemorrhage over here. अच्छा, दो फाइंडिंग्स बिल्कुल. एंड द थर्ड यू वोंट बी एबल टू पिक अप बिकॉज वी हैवंट डिस्कस्ड दिस. थोड़ा सा कलर के बारे में हम देख लेते हैं. तो द कलर ऑफ द डिस्क, डू यू थिंक इज इट hyperemic or is it pale? It's one of the two.
Pale.
Hyperemic.
It's hyperemic, right? It has a color which is similar to the rest of the retina, and it's yellowish or reddish in color generally. So on slit lamp examination or fundoscopy, we have a hemorrhage. तो नहीं कहते थे, चलो hemorrhage कौन सा hemorrhage shape होगा? Hemorrhage at disc. At disc, we have a hemorrhage at disc. The second thing is we have blurred margins of the disc. And the third thing is we have hyperemia of the disc. ये चीजें हमने किस डिजीज में देखी थी? अभी थोड़ा हमने कल ही परसों पढ़ा था. We saw these things. Papilledema में देखा था. We also saw this in papillitis. If you've visited this board and you saw that classification of optic neuritis, उसमें एक papillitis थी जिसमें edema भी आपको मिला था hyper. So now we perform the pupillary reflex. हमें disc पे changes नजर आ. Pupillary reflex shows an RAPD in the right eye. ठीक है. Extraocular movements are normal and they are painless. So, चलो अब what are the differences in this case so far on the basis of examination from the one we did last time, the two we did last time? We discussed papilledema and we discussed papillitis. So what are the differences? We're seeing things different here. One thing is same, that is the slit lamp visual acuity. Visual acuity is decreased, so you notice that in papilledema visual acuity might not be decreased, or दूसरे visual acuity भी ठीक है. So you notice that the slit lamp and fundoscopic examination, they reveal more or less the same things which we saw in papillitis and which we saw in papilledema. Isn't painless hai? Movement is painless. So we saw painful movement in retrobulbar neuritis, which is a classification or subtype of optic neuritis. So that is the first thing. So is this this person has visual loss which is unilateral. So it's unlikely that it's papilledema. तो चलो थोड़ा सा हमने idea हो रहा है कि all right, this is something different from the first two. But what is this? We're still not sure. Okay, we cannot make a diagnosis. We have a list of differences from which we've excluded retinal detachment because we cannot see a retinal detachment. We included vitreous hemorrhage because we can not see any vitreous hemorrhage, even though there's a retinal hemorrhage. Wet ARMD because we do not, the macula is unremarkable for discussion sake क्योंकि वैसे हम इतना इसमें नजर नहीं आ रहा. And it's not CRAO because a CRAO has attenuated vessels and a pale retina, not just a pale disc. The whole retina is pale. So, okay. But due to the presence of disc edema, we have two further differentials. One is optic neuritis. The second is papilledema. Unilateral papilledema, because unilateral papilledema can happen if something is pressing only on the optic nerve of one side. थोड़ा सा हमारे differentials इसके बारे में. How should we investigate this patient? Which investigation is that?
Perimetry.
Perimetry, right? This is Humphrey's visual field. So when we perform a Humphrey's visual field or a perimetry of this patient, this is what we are seeing. इस आई में abnormality नजर आ रही है हमें visual field पे. Right पे नजर आ रही है. ठीक है, it's very simple. What can you see about this visual field? What is abnormal? You know that this large blind spot, मतलब blindness or ठीक है, there's a scotoma. If I draw a line from मतलब line तो पहली बनाने की जरूरत नहीं है. We can see that the scotoma, it's strangely enough, it's refraining, it's containing itself inferior to the horizontal meridian. ठीक है, horizontal line जो लगी हुई है, जो because this is a macula, right? मैक्युला से जो हॉरिजॉन्टल लाइन पास कर रही है, द स्कोटोमा इज बीनीथ और बिलो दैट, इट्स नॉट गोइंग अप, साइड से थोड़ा सा आ रहा है, but the rest of it's maintaining that relation, or it's maintaining the respect of that horizontal line. Such a scotoma, ठीक है, when it मतलब थोड़ा सा जब ये horizontal meridian के ऊपर है या नीचे है, it's called an altitudinal defect. And since the scotoma is present inferiorly, this is an inferior altitudinal defect or altitudinal scotoma. So what you're seeing at the right side is an inferior altitudinal scotoma. Humphrey's visual field cry, this is what you find. Is there any other investigation which you would like to perform?
FFA.
A fundus fluorescein angiography. Fundus fluorescein angiography में क्या करते हैं हम? We inject a dye in the arteries. The dye मतलब it passes through these arteries, retinal arteries and the retinal veins. And we take pictures at different times. It will tell us how much time, मतलब regular हमें पता है कितने time में arteries में होंगे, इतने time के बाद capillaries में आ जाएगा dye, इतने time के बाद veins में आ जाएगा. So FFA tells us how much time, if there's a time delay or if the dye is passing too quickly. That is the first thing. And the second thing, it tells us whether the vessels are leaky or not, because there are some areas which don't have any vessels and they should be free from fluid or leakiness. Those are normal areas which we can pick up from fundus fluorescein angiography. Right? So the FFA is abnormal in this patient. It's abnormal at disc. Disc abnormality in simple terms, I write it down. Disc abnormality क्या है? इतना ही होगा कि FFA आपको पता होना चाहिए कि it should be abnormal. बाकी जो आगे बात है, it's above our मतलब level, it's not relevant to us, but there's a delay in the dye. We can delay in the dye reaching the disc or reaching afterwards compared to the left eye. So this is what you find on fundus fluorescein angiography. Any other investigation which we did in the previous two diseases which you would like to do in this patient as well? सोचें और मुझे बताएं.
ESR.
ESR, BSR, blood sugar random. You're asking for BSR or ESR? I'm not sure. ESR or BSR? Is it B as in a bee or E as in an elephant?
Elephant.
Elephant. So you want to do an erythrocyte sedimentation rate. What does an ESR indicate? ESR indicates that there is an increase in acute inflammatory products, especially fibrinogen, and the presence of that leads to greater rate of erythrocyte sedimentation. So in the case, erythrocyte ESR is unremarkable. Remarkable examination होती है, it's normal. It's a good examination. Sensible examination, and you will know why this is a sensible investigation to perform. और आप क्या करवाना चाहेंगे?
MRI.
MRI. So do you have any indication to perform an MRI at this point? Okay. Do you have any indication to perform an MRI?
Papillary edema की वजह से.
Papillary edema. So you're thinking this is papillary edema. Okay. So that lesion is only present in the right eye. So you're thinking that something is causing unilateral papillary edema. So either it's in the orbit or it's close in the orbital canal or the canal of the optic nerve, optic canal. You're thinking something is there. So you want to perform an MRI or a CT scan. You think that something is there. It comes out to be unremarkable.
MRI में soft tissue की भी तो lesions वगैरह नजर आ जाती है ना?
बिल्कुल आ जाती है. MRI soft tissue के देखते हैं. Soft tissue या masses को भी
nerves का कोई issue
बिल्कुल नजर आ जाता है. You're right, बिल्कुल नजर आ सकता है. We want to eliminate intraocular lesions. That is correct. We want to eliminate intraorbital too. Intraocular, if there was an intraocular lesion, we would have picked it up on fundoscopy. If we could not have performed a fundoscopy, then a B scan or an CT or an MRI for intraocular lesions would be a specific, that would be a good investigation. तो we can see तो हमें intraorbital हमारी कोई intraocular कोई इस वक्त indication नहीं है. Intraorbital बिल्कुल unilateral papillary edema, it's likely that there's an intraorbital lesion which is causing that. हो सकता है there's a nerve tumor which is causing compression of the nerve. That is why there is severe papillary edema. You can be correct. That can be the case. However, our CT and MRI are unremarkable. Any other investigation which you would like to perform in regard to a symptom which we discussed, especially for optic neuritis? There's something called color sensitivity. Color sensitivity in patient के हमें test करनी चाहिए. Since we're thinking the optic nerves involved. Okay, we did this for optic neuritis, we did this for papillary edema, and we're also doing this now because this patient might not be aware. Yes, they're not aware, they have red desaturation. This means that they cannot perceive red color as well. क्या गड़बड़ लग रही है आपको? We've done all the investigations which we did last time. Okay, there is unilateral disc edema, disc hyperemia. The MRI and CT scan are unremarkable. इसके बाद अगर हम CSFP perform करें, it will be normal, even though we don't have any indication for that. FFA shows abnormality in the dye leaking out. The color sensitivity shows red desaturation, and there is an RAPD.
He means optic neuritis.
Okay, the diagnosis is AION. What is AION? AION क्या होता है?
Acute ischemic optic neuritis.
It's anterior.
Anterior.
It's anterior ischemic optic neuropathy. This is the diagnosis of this case. Okay, इसको हम थोड़ा सा देख लेते हैं. Why is this the case? Why is our diagnosis anterior ischemic optic neuropathy? And we'll relate this to the symptoms and the signs of this patient, and we'll relate this to the anatomy which we discussed today. So our diagnosis is anterior ischemic optic neuropathy. That's good. That's a good diagnosis. How should we manage this patient is the next question. चलो मैनेजमेंट हमने इन दोनों केसेस की एक बात बाद में देख लेंगे. So you're right. The diagnosis is anterior ischemic optic neuropathy. Okay? Because this patient has an RAPD and he has disc edema. So you're for sure, and there's color sensitivity, there's a red desaturation. So you're sure that the disease process is affecting the optic nerve. Now, we know three types of optic neuritis: papillitis, neuroretinitis, and retrobulbar neuritis. It is not retrobulbar neuritis because, for one thing, there's no pain, and the extraocular movements are normal and painless. And retrobulbar neuritis, you cannot see anything on the disc. The disc was normal. There is present something on the disc. So this must be either papillitis or neuroretinitis. Since we cannot appreciate a macular star, for those who don't know, it means that there are hard exudates present in the star formation around the macula. Since there isn't a macular star present, this is not neuroretinitis. So it can be papillitis. ठीक है, एक हमारा डिफरेंशियल था papillitis का. But there are certain features which differentiate it from papillitis. The first thing is that the MRI or CT was normal. The ESR was normal. ESR normal होता है तो ESR is usually in inflammations and infections, right? So if it's normal, it's unlikely that this person has an inflammatory papillitis. Second was demyelinating disease, multiple sclerosis. आपको MRI और CT पे कोई plaques नहीं मिले. You did not find any periventricular calcification. So that optic neuritis, papillitis becomes unlikely. ठीक है? तो I'll discuss this. मैं भी इसको थोड़ा सा incomplete छोड़ रहा हूँ because I want to discuss both the cases for today side by side. ठीक है? इससे हमारे लिए काफी आसानी होगी. So let's look at this case.
भाई वो जो रेड कलर का आ रहा है डीसैचुरेशन, तो उसका मतलब ये हुआ ना कि अगर सिर्फ रेड का आ रहा है तो ओनली स्पेसिफिक न्यूरॉन्स आर बीइंग डिस्ट्रॉयड.
Specific neurons, इसका मुझे आई एम नॉट श्योर व्हाई दिस हैपेंस. इसकी फिजियोलॉजी आई एम नॉट श्योर अबाउट इट. बट मैंने भी तक ये पढ़ा कि ऑप्टिक नर्व में जो लाइक आई सेड लास्ट टाइम कि उसकी जो डिजीजेस प्रोसेसेस थे उसमें रेड डीसैचुरेशन इज अ प्रोमिनेंट सिम्पटम फॉर सम रीजन. आई एम नॉट श्योर, इट्स नॉट इन माय नॉलेज. और मतलब किसी ने अभी तक पूछा नहीं. अब मैंने इस पे फोकस होते हुए देखा, सो आई डिडंट फाइंड इट मतलब enough to dedicate my time के उसमें पूरी रिसर्च करूं. So I'm not sure about this, why this happens, but I do know that this happens. Red desaturation is a prominent symptom of optic nerve diseases, and it stays for a long time. So why this happens? You're right. Obviously, you're right. Some of the neurons which have red pigmentation, they're being affected. But why are they being affected? Why? एक तो मुझे पता है कि red spectrum on the ultraviolet scale of light, red has the highest wavelength. क्या वजह है? I don't know. बिल्कुल हो सकता है. This can be true. I haven't read this about it. Fatma is telling us. So I'll take her word for it. Unless I find anything or if there's any evidence or I read anything to the contrary. Red cone fiber is the most sensitive damage. That might be the case. So let's move on to our second case. अच्छा बल्कि ऐसे कहते हैं, since there are 8 minutes left, I'm going to end this session now. एक continuity में चलता रहे काम तो अच्छा रहता है, तो आधा डिस्कस हो पाएगा. So while I'll be back in a minute, ठीक है? We'll start with our second case.